Thank you very much, Shushmita, for having me here. And it was very good news that the course, this is an invited course. Everyone liked it last year very much, that she was invited again to run this course. And I'm going to talk to you on, are there factors at baseline that can predict glaucoma progression? It's a little bit of a difficult topic because there are so many parameters and so many risk factors that are involved in determining whether this patient is going to progress. So it's often hard to determine in a particular patient the course that glaucoma is going to take, and I think that happens to all of us when we have a patient sitting in front of us actually. How soon or how slow is it going to progress? And progression, however, I have learned, and all glaucoma specialists learn as they age and their hair grows white, that progression is a given. And one has to be really lucky, even while giving what we consider as adequate treatment, to identify a patient who does not progress over a period of time. Amongst the various parameters that constitute risk factors, I'm going to deal with a few. One of them is age. Second is pseudoexfoliation, disc hemorrhage, beta zone, Trance-Lamina Roza pressure differential, compliance, and of course there are other vascular parameters such as venous occlusion, very high intraocular pressure, cardiovascular factors actually. So go back to the Central India Eye and Medical Study, and we found that there was a strong correlation with age with the prevalence of glaucoma, and this is widely true for all other population-based studies as well. The prevalence in this study increased significantly with age, and for the study population of 40 plus years, the prevalence was 3.45%. For 50 plus years, it was 5.11%. And for 60 years and above, it was 7.5%. And with better diagnostic modalities, I always say that in a hall of 100 people, maybe there are 10 people who have glaucoma and a few more who are at risk or are glaucoma suspects actually. So as a corollary, we may suggest that age is also a risk factor, not only for development, but also for the progression of glaucoma actually. So pseudoexfoliation, diagnosis, the presence of higher baseline intraocular pressure and greater number of medications and worse baseline visual field mean deviation were significant risk factors for progression, but don't take everything as face value because everything goes together. And I think the first thing that happens is raised intraocular pressure. We did a study many years back and we examined 113 eyes with pseudoexfoliation. The mean intraocular pressure was 16.6 and the range varied from 7 to 60. And of the 113 eyes, there were 16, just 14% who had an intraocular pressure at that time of more than 21 millimeters of mercury, and the mean intraocular pressure in eyes with more than 21 millimeters of mercury was 34 millimeters of mercury with a range of 22 to 6. So I think there's a thresholding that takes place in the evolution or staging of pseudoexfoliation. So when we segregated eyes with pseudoexfoliation on the pupillary margin, those eyes had a mean intraocular pressure of 38.5 millimeters of mercury, and those eyes that had pseudoexfoliation on corneal endothelium and in the angle had an intraocular pressure of 34.0 millimeters of mercury, indicating that if you see pseudoexfoliation on the pupillary margin or on the corneal endothelium, then surely this is a patient that has a very high risk factor and you need to follow up and reassess and treat this patient even more aggressively actually. The other risk factor is the presence of optic disc hemorrhages. They were only detected in 17 out of roughly 9,000 photographs, and the prevalence was just 0.19% in the Central India Eye and Medical Study. They were found to correlate with older age, higher systolic blood pressure, arterial hypertension, diabetes mellitus, even myopic refractive error, along with neuroretinal rim area, retinal nerve fiber layer cross-sectional area, and of course the presence of glaucomatous optic nerve damage actually. This is from another study from Zangwill from California, and the rates of retinal nerve fiber layer thinning was significantly faster in those quadrants that had disc hemorrhage compared to non-disc hemorrhage quadrants. So I think that's very important, that you need to follow up these patients. It's actually easier to follow up the patients for progression because we know that segments and quadrants where you see a disc hemorrhage are likely to progress faster. With unchanged treatments, the rates of retinal nerve fiber layer loss in disc hemorrhage quadrants were much faster. And with intensified treatment, the rates of retinal nerve fiber layer in all quadrants with or without disc hemorrhage seemed sort of significantly reduced actually. So of course disc hemorrhage is an indication for more aggressive intraocular pressure lowering actually. And these are some examples of disc hemorrhage, and you can see the disc hemorrhage in the right eye. the disc hemorrhage in the left eye. And this patient was pseudophakic in both eyes with pseudoexfoliation. The good thing about it is that, you know, there is no retinal nerve fiber loss. There is a dip here, but that is just a variation in the way that the retinal nerve fiber layer is distributed around the optic disc, but it's not really a retinal nerve fiber layer defect. So I think we're extremely fortunate to have detected this patient with disc hemorrhage. We know we're going to have to follow up this patient, and the patient has got pseudoexfoliation in addition and elevated intraocular pressures. And this is a patient who had disc hemorrhage in 2012. This is the left eye, and you can see the retinal nerve fiber layer is normal. And then in 2017, 5 years later, you have a broad wedge defect, and you have a significant retinal nerve fiber layer loss associated with the disc hemorrhage quadrant. And that just proves what the other study was trying to tell us, actually. Beta zone is a region of parapapillary atrophy. It shows chorioretinal atrophy and visibility of the choroidal blood vessels and the sclera. And there are many studies that have suggested that in eyes that progressed, the neuroretinal rim was significantly smaller and beta zone was significantly larger. And that in patients that had a large beta zone, the expansion in the beta zone was also associated with the increasing loss of visual field, or that the presence of beta zone in that segment was associated with increasing visual field progression. But I think that there are many factors that we don't understand about the beta zone. For example, this is a patient that has got almost a 360 degrees beta zone, but the beta zone is not tremendous. There are some patients where you find a very wide beta zone, but that's not the case here. It's almost as if it's uniform right from superior to inferior, and there is 360 degrees retinal nerve fiber layer loss, although the loss is more in the superior and inferior quadrants. So here we are not able to say that there was beta zone in one quadrant and therefore there was increasing visual field loss in one quadrant. And there are many variations of the beta zone that we are still not able to understand and correlate with the retinal nerve fiber layer. However, it is important to understand that there is a beta zone in many eyes with glaucoma, but it's also important to understand that there are many eyes that do not have glaucoma that still have a beta zone. So I think we need to understand beta zone a little bit better, but for the time being, one must assume that it is a risk factor in glaucoma actually. The other important possible risk factor that has been spoken about is the trans-lamina cribrosa pressure differential that has been defined as the difference between the intraocular pressure minus the cerebrospinal fluid pressure. It's further considered that since the lamina cribrosa is considered to be the primary site of damage to the nerve fibers, the pressure zones around this may be very, very important in causing glaucomatous damage. We are not able to measure the CSF pressure or the pressure around the optic nerve, and that is where there is a little bit of difficulty in understanding this whole concept. But from various things we have learned, and also from population-based studies, for example, in the Central India Eye and Medical Study, the intraocular pressure in patients with glaucoma was 17 millimeters of mercury, and in the non-glaucomatous eyes it was 13.7. The CSF pressure in the glaucoma group was 7.6, which is much lower than the 10 millimeters of mercury in the non-glaucomatous group, and therefore the trans-lamina cribrosa pressure differential was almost 10 millimeters of mercury in the glaucoma group versus only 3.6 millimeters of mercury in the non-glaucomatous group, telling us that a lower trans-lamina cribrosa pressure differential was safeguarding the damage to the optic nerve in these patients. Non-compliance is important. We don't pay enough attention to it because it's really not exciting for us, but it is important. And we did a study, and I would just give you an example in this patient where she had a non-compliance index of 33%. We just take it over the last 90 days, how many days she missed her drops, and we get the non-compliance index. And the non-compliance index had a negative correlation with visual acuity, with the nozzle touching of eyelashes, showing that these patients are not careful with how they put the drops, and a completely abnormal technique of drop installation. So these are the various risk factors that I think we should consider when we have a patient of glaucoma in front of us. Thank you very much for this opportunity.